centers and the primary care associations. And so, actually, I think this could be a good thing for everybody. It's nice to have somebody who understands health centers and public housing, primary care in particular, be working at the PCA level. And, so hopefully we can, share resources and collaborate and do all that kind of good stuff in addition to your work as chair of the advisory group.
Yeah, and in fact, while I've been getting to know the health centers in this area, there are a couple that have public housing communities right across the street who I don't think have really realized the benefit of targeting their services to a population such as public housing residents.
Right. Well, that's terrific because we'd like to encourage some folks to to sign on.
Right.
And we've talked to the folks up south of Boston and Quincy. We followed up with them a little bit ago, and I think they're interested, but we just have to work out some of the details in terms of them applying. And of course, funding is always an issue, but we won't get into that.
Sure.
We'll never start talking about it. And Karen, I don't know if there was anything else you wanted to say to the crew, because I know you won't be able to stay with us for the whole thing, so I just wanted to give you an opportunity.
Sure. No, absolutely. This is public housing is what I started. I was thinking about it, and it's been 27 years since starting out and providing support to public housing grantees. So that's a long time just to get it, to cut it off. So, and just as my colleagues here on the phone, guys, it's still a family. So, it's a hard sell, but still, when we see each other, it'd be like reconnecting again.
Well, and I just want to say, Karen, we have, you have been a great friend of the program and of the National Center since its inception, since we started working on this stuff, 16, 17 years ago. And I can't thank you enough for all your time and energy and guidance, as to what's important and what folks need, and your kind of unique ability to encourage folks to work together, for the good of everybody in the program. So, just thanks for all you've done and continue to do.
My pleasure.
Anyway, well, I'm going to move on to the agenda if we don't mind, because we got a lot of things to cover, and I know we don't have a lot of time. So the first thing I'm going to touch on is just a quick review of the agenda, which is the PHBC symposium. We got 3 top issues that we want to discuss quickly. Some PHBC trends that I think Jose wants to review. Want to give you a quick update or discuss a little bit about the Public Housing Task Force meeting at NAC in March. And last but not least, talk about the Public Housing Primary Care Radio, which Jose is very excited about. And I'll also give you a quick update on the National Resource Center, which is the collaborative effort between all the national cooperative agreements, but I'll try to keep that brief. But the first topic is the Public Housing Primary Care Symposium. Based on the recommendation of the advisory group at our last call, which it was right around the 1st of December, we have pursued piggybacking on the NAC conference in Orlando in August. And the date that we had all agreed upon when we talked way back now was August 23rd. And so we have pursued that. We had it took quite a bit of effort kind of to work some of the details out with NAC. Some of the delay had to do as much with an illness of a couple of folks at NAC who were actually responsible for the conference. But we are working with them now. They are positively disposed to us, proceeding with that date at the Hyatt Regency. We've also pursued a backup plan about conducting the conference in Orlando, but at a venue nearby, so people would at least save money on the airfare. But we're keeping that in our back pocket. Just in case anything should fall out with the Regency. We did want to talk to folks a little bit about the agenda. and especially a big part of the agenda for the conference, and it stems from the BIPIC, the Bureau's priority and everybody's priority right now, which is diabetes. And so I'm going to let Jose kind of explain what we've been, or what we're proposing at this point. So.
Thank you, Bob. Well, as Bob mentioned, the main priority right now for HRSA is diabetes. So one of the topics that we are planning to include at the symposium is diabetes. We've been working with NAC and a group of physicians. We are putting together a roadmap on how health centers can improve the A1C greater than 9 performance in clinical quality measure. So the idea that we have is to have a panel of physicians, either HRSA's Chief Medical Officer or NAC's Chief Medical Officer, and invite someone from the American Diabetes Association. We've been working very closely with the American Diabetes Association and the program that they have for primary care, which is Diabetes is Primary. This is a training that they have for primary care doctors and all the clinical staff working in primary care, nurses and nurse practitioners and diabetes educators. So that's one of the issues that we are planning to address. There are other issues that probably we are going to mention when we touch the 3 top issues in public housing primary care. But right now, this is the most important topic that we are planning to include.
Okay, and in terms of delivering that training, there are a number of other things that folks, want to address, during the symposium. And we also talked about smoking cessation, because as you all know, HUD is, as of August 1st, smoking is banned in all public housing nationally, and we all want to use this as an opportunity to really aggressively pursue smoking cessation and prevention. So that's one thing. We also wanted to deal with, if we could, emergency preparedness and climate change. And third, we really wanted to address opioid addiction and treatment and prevention on that score. And we wanted to run those topics by you guys and kind of just get some feedback as to whether or not you think we're capturing the important issues. And also, should we also include, a segment that deals with, more financial and administrative matters, in general, whether it's, Medicaid reimbursements or sliding fee scale or the new, the new program requirements manual or any of those things. So if anybody wants to kick off and respond, if you'd like to respond first relative to diabetes. Anybody have a thought on that? Wayne, Alan?
I'm fine. I think that's a great segue to get started with some of the clinical measures and putting more emphasis there. What I would like to maybe suggest that we haven't talked a whole lot about outreach. We are still having, particularly where we're starting new centers or sites, but outreach and getting our populations into our centers and some strategies for that would certainly be helpful.
Okay.
I think.
Okay, that sounds good.
This is Kent Terrell from Macoupin. I'd like to see best practices or strategies of what we can do to provide a lot of education outreaching into the health centers. Most of them have some type of a community center, and what is the most effective way to make segues into coordination on site.
Okay, that sounds great.
We certainly agree with you in that diabetes, smoking cessation, especially in our case, emergency preparedness, proved to be very important. I guess for all the residents in the coastal areas, this emergency preparedness is really a must. It's really made a huge difference between our operations and those operations without emergency preparedness plan.
Yep.
And we believe it could just knock you out for a good time, and will influence, on all the other factors.
And Alan, if we were able to maybe put together a panel, I think we'd probably like to have you and Joe Fuentes from Houston on it, because you both had pretty severe weather and a really rough time. I think you guys rougher in Puerto Rico, obviously, but I think it'd be very instructive as to what people need to be ready for. And perhaps we could bring in, a couple of other folks who have some expertise in some climate change related issues. So I think that would be great.
Yeah, we'll be very pleased to participate in that. And quite honestly, emergency preparedness is not about a year, but probably about 3 to 4 years in preparation for these kind of climatic changes.
Okay.
This is Kent Terrell again from Macoupin County Health Department. Trauma to me is almost the number one issue. Because I don't know, we screen for ACEs and social determinants of health, and we really, in many cases, can't get anywhere with obesity, diabetes control, actually anything, compliance care plans, behavior changes, until we help people resolve and heal from whatever traumas they have had. And in the lower income, it's through the roof.
Wow.
And
Yeah.
I think it's an extreme, almost has to be addressed. I don't think we can get to medical control, to good health, mentally, emotionally, and physically, unless we deal with people's traumas first. We'll never control costs.
I'll take it. You and Jose are trying.
Go ahead, Sarah.
Oh, hi. This is Zara. Ken, totally can relate to that, which is why we've been developing these services around our circle of care, social determinants of health specifically, because so many of our populations, whether they're refugees, immigrants, veterans, homeless, people that are coming out of the correctional facilities, it's like unless we can deal with those basic challenges, issues related to their experiences, prior adverse conditions and experiences, including trauma, there's no way that that they're going to achieve those health measure outcomes, that we're being held to. So we'd love to be able to, kick around some ideas of what's worked, and part of that solution for us has been putting together the outreach specifically around culturally diverse populations. And that's helped a lot with the diabetes. And Jose, the one last thing with that is the predictive analytics project that we did around diabetes, and including pharmaceutical medication adherence. It's really fascinating what we came out with. We'd love to share that.
Excellent. Thank you, Zara. And thank you for bringing the trauma issue up. We've been having conversations with SAMHSA on the HRSA SAMHSA integrated health solutions, and we are going to develop a program, training program on trauma. But I believe that this is a great topic that we can include at the conference. Yep. Thank you so much for the feedback.
That's great.
The other one thing I wanted to mention was the opioids. That's like a real issue for us, and I'm sure lots of other places. We have a medication-assisted treatment program that is really growing, and we've applied to SAMHSA to be able to expand on the behavioral part of that treatment. And I really hope it's there, because and we haven't really been very successful with SAMHSA before. So hopefully that's something that we can cover at the symposium more about opioid programs.
Okay, that is great. Thank you, Sarah.
You know, Zara, we delivered an opioid panel and session complete with training on the
NARSA, sorry.
What's the medication?
What medication?
Medication.
Naproxen.
Narcan or naproxen.
Mm-hmm.
And we and it was for at the NASA or the NARSA conference, which is Sam Little's group, the resident services group. And it was incredibly well received. We had a room full of residents and resident council members from housing authorities. And, sometimes you're concerned that you won't get adequate participation. And once folks started talking, it was like everybody in the room had a relative or a friend or a personal experience where they had either become addicted through some medicine that was prescribed, or they had somebody who was picking up the stuff illicitly, and they were very, very engaged, incredibly engaged, and really wanted to know how to do more, and really appreciated the training. And we can even do the certificates and all that kind of stuff on site, the training in how to administer Narcan and so on, which is very simple. That sounds like a great program. It sounds like a great idea for a session.
Mm-hmm. Mm-hmm.
Anybody else? Alan, what about finance and administration? What are we missing on that?
Well, I don't really think you're missing that much at all. I think you've got some good projects there. So, but I would like to say, I completely agree with the making the opioid abuse and treatment a major topic. Emergency preparedness makes sense now, given all the issues of the past year, and you can't go wrong with having diabetes. If we're going to do finance, it's always good to be able to have some presentations on sustainability models. It's just so difficult to be able to figure out what we're going to have to sustain.
Okay.
But
what about the new program requirements manual?
Well, as a matter of fact, in about 37 minutes, I jump in the truck to drive to the airport. So I'm going to the compliance training manual training, the compliance manual training, as well as the FTCA. So I think those are always two good topics. FTCA is always a win, especially if you can get somebody from the LIFER. And then the compliance manual is on the top of everybody's mind. I'll know a lot more after I finish up this. The training is all day tomorrow, Wednesday, and Thursday, and I'll know more. But I can't imagine that those wouldn't be great hot topics for everybody to hear.
Okay.
Advocacy is always one that I'd like to see us do more on too.
Advocacy?
There's so much swirling around about what we can do in ways of advocacy, and where do we cross the lines, and what's the difference between advocacy and lobbying.
Yeah.
And I think that's another aspect that'll be in the compliance training as well, come to think of it. But nonetheless, I think that's we've all got to be able to ratchet up our advocacy, because it's a precious few health centers that are doing all of the or the majority of the advocacy, and so we really need to make sure that we are at the table of advocacy. Otherwise we'll be on the menu.
Right. Well, that's good. That's good.
Hello, this is Sarah Lang in Columbus, Georgia. Will there be anything to address new starts, new relationships between community health centers and public health organizations? Is that something that is normally addressed in the symposium?
It has been in the past. Honestly, we had not really talked about it a great deal for this year, but if it's something you're interested in, we will put it on the list. And if we don't address it at the symposium, then we will put together a separate program for the new starts.
You know,
Okay.
as I recall, that was really helpful to me some, whatever it was, 10 years ago or thereabouts. I'm trying to remember the name of that fellow, what was he in the Boston area that did the presentations?
Is it Jim Hunt?
No, it wasn't Jim.
No, from Boston.
I'm drawing a blank. He used to be with you guys.
Oh, David.
David Vincent.
David, that was it. Yeah, he did a great job.
Well, you're right. You know, that's right, because David's originally from Taunton, which is just south of Boston. That's right. Yep. Yeah, and I know that, in fact, we just went back and forth with David on a couple of things that he wants to do this year. So I think that maybe this would be something we should re-enlist him on.
Mm-hmm. Mm-hmm.
Yeah, thanks for bringing that up.
And
And
that one fellow that, did the
also,
presentation-
what about the telehealth issue?
That's another thing that we can include. Yep.
Okay.
Yep. Mm-hmm.
Now, one of the things I want to say to everybody is there are a lot of great ideas here. Now, the session we talked about based on our last call is 1 day. So
That's true.
So we're going to have to, take a look at a couple of practical things. And
What's the problem, Bob? Can't you have 1 day and 7 tracks or something?
we'll have 7 people in each room. Well, here's the tricky part of it. And Jose talked about the diabetes as primary session. And this is something we really want to get your feedback on. Diabetes as primary is at least, well, they do have a 1-hour version. Sorry, happens to everybody, but they do have a 1-hour version, but the version that is probably, easiest and most useful is the half-day version. So that session alone would take half a day. Now, the session is designed definitely for clinicians, but also folks who are involved in outreach.
Mm-hmm.
So I think that would be a very nice program. And our question to you guys is this. Say we've got, let's say we've got 150 people there. Do we do one big session and everybody is in the diabetes as primary? And it is, obviously a priority of all of us, and it's certainly on all our, all of our work plans and all that kind of good stuff. And it's a super important issue. Or do we break it off and say, okay, we're going to have a separate room, and folks who want diabetes as primary go off and do that, and then we focus on some of these other issues, in another room, in another breakout.
So, Bob, if I was going to pick one issue, frankly, for me right now, it would be the intensity I feel to make sure that we address the opioid abuse and treatment. So that would probably be my one issue if we were going to have one issue.
Okay.
I understand, though, if we can have more than one issue, probably would be opioid abuse and treatment and diabetes.
Okay.
Now, we've been talking to the American Diabetes Association, and this diabetes is primary training is, the target audience is clinicians.
Yeah.
So the idea that we have is if we can have clinicians from the public housing primary care grantees and the health centers that are located in or immediately accessible to public housing and provide this training at the same time that we're having the other sessions. But we would like to have the clinicians and the outreach people and everybody who is in contact with the diabetic population to receive this training. The question is whether do you think this is disruptive or do you think this can work out well?
Well, quite honestly, what historically how it has happened is that you kind of go to one and then miss the other, and it would be a good idea to have everybody, looking at the same page.
Okay. All right.
So is everybody good with that?
Yes.
Okay.
Yeah.
Okay.
Yes, Wayne Rowe.
Okay. All right. Excellent. All right. Well, what we're going to do is go back and kind of, over the next couple of weeks, we'll be putting together a more detailed agenda, and we'll probably circulate it to you guys. Mm-hmm. So as you have, feedback, just be cognizant of the fact, as I say, we've got a limited amount of time, and I think we've got a lot of important issues. So as you look at it, just when you do get a more detailed agenda, just keep that in mind. And we really appreciate the suggestions. A lot of good ideas.
Yes.
So that sounds great. Jose, do you want to talk about trends?
I believe that before we talk about trends, we need to talk about the public housing meeting at the P&I conference and the
Okay.
top issues.
You want to do that now?
Yeah.
Okay, that's sure. Okay. Will all you guys be going to P&I in March?
This is Zara. I will be going.
Okay. Who else
Yeah,
go?
this is Alan. I'll be there.
Okay.
Wayne Rowe, I will be there until the 15th.
We're going. We'll be there.
Quintero, no, not going.
Not going. Okay. Anybody else? Because we would like folks to come to the Public Housing Task Force meeting, and what we wanted to just talk about is I think we sent to everybody a write-up on the 3 important issues.
Yeah, but I have them here.
And I don't know if folks had a chance to read through it, and if you didn't, that's okay, because there are 3 issues that we addressed earlier. But smoking cessation is one, and then we're going to follow up with discussion on what else we got, opioids and emergency preparedness.
Mm-hmm.
So I mean, first of all, and going back to, I guess, the earlier discussion, I think the trauma discussion is a very interesting point, because
Yes.
it's something that Jose has really been pushing. Some of our focus, is dictated a little bit by the Bureau, and so I think trauma is something we need to kind of push to the forefront. And I know that Dr. Leone here has wanted to do that for some time, so we will definitely do that. But
I would like to see that as part of the diabetes, the whole diabetes program on that day in August. Actually, there's an extreme tie between chronic disease development and trauma, unresolved trauma. Let's go that far. And I just don't think we're going to get where we need to go without addressing it, and the sooner the better.
Okay. Well, I think then that based on this, based on the point that's been made a couple of times really well, we should add that to the agenda.
That's definitely.
And I think we should, I don't know if we can revise this maybe and send it over to, and maybe talk to Melvise and just say that
that's right.
we want to push that up. Okay, that's a great point. I'm so glad you guys made it. Excellent. So we'll do that. Any issues? Do you guys have any issues with the issues that we've identified? And I know that the last call, we talked a little bit about the HUD smoke-free rule and what folks were doing and weren't doing. And I'm just going to give you a little bit of information. Harvard did a study, and they reached out to some of the public housing agencies. And amongst the public housing agencies, only about 26% of the executive directors of the housing agencies were aware that community health centers were assisting their health center in the implementation of the rule and smoking cessation and prevention and all that stuff that goes with it. Now, I think some of the issue has to do with EDs, that housing authorities don't know everything, and also just the definition of implementation. I think really more the focus is, or really what the housing agencies are looking for the health centers, is to assist them with some combination of education and outreach, as well as treatment and prevention activities, whether it's medication-assisted treatments or counseling or all those kinds of things. And I guess I just want to put the question to the group. And that is, are you guys, making any special efforts with the housing agencies, and at the same time, have the housing agencies made any special efforts with you to try to seek out your assistance and to try to, take advantage of this kind of incentive? It's funny, in a survey this is another interesting survey result, the residents in public housing, almost half of them think that they have to quit smoking. Okay, they don't realize that it's not that they have to quit smoking, it's that they can't smoke in their units. They have to be at least, 25 or 50 feet from the building. So, and I know that technically it's a bad thing, but I'm kind of glad they think they have to quit, because hopefully they will try to quit. So,
Yeah.
so how can we assist them? And have you guys been doing anything special? Have you gotten any additional inquiries from the housing agencies? Have you guys reached out to the housing agencies?
Well, yeah, we have at Macoupin, but the Housing Authority Executive Director is on my health center board.
Okay.
We've been working together for months and months.
So as part of that effort, Ken, have you guys been doing anything special?
Yeah, we've been providing, going over the rules with them. We've been providing more intense tobacco cessation efforts, education efforts on secondary and tertiary smoke and its health problems, and just letting them know that, helping them with signage and things like that, and basically when they come to the health center, talking to them about the new rule that, what is it, July 1 is coming. So yeah, we've kind of been working pretty good and putting things in. They kind of ran out of money there, so they're only going bi-monthly on their newsletter. We're putting something in their newsletter every month now.
Okay, great. And Alan, I know you have the Housing Authority Director, I think, on your board as well.
I think she's the deputy director, but yeah, we do.
Okay.
Yes, we do. And as a standard procedure, all patients who are smoking, they're provided with a referral to the state Department of Health, where they are kind of urged to follow a protocol. The problem in here is that the Department of Health just doesn't enforce the protocol.
Oh, okay, interesting.
For smoking in the state.
Okay, and
so they kind of mingle around. As that doesn't really work, then they are referred to our psychologists, and then we work with them.
Okay. And
so there is a kind of a missing link there with the government, state government agency of health.
Now, do you work closely with them at all, Alan, or are they kind of at a distance?
Yes, we work closely. You mean with the population of the public housing?
No, with the chronic disease or the tobacco control folks in Puerto Rico.
Yes, we do. We have a mental health department. Yeah. And they're referred to our psychologists to work with them. And the model units also bring on board a psychologist into the public housing units.
Okay.
We serve public housings with model units.
Okay. Mm-hmm. Is there anything that the public housing agencies could do, with you to more effectively pursue smoking cessation, or more successfully pursue smoking cessation for residents?
Well, we really depend a lot on the State Department of Health for completing our intervention with the patients. And as that is missing, we are doing it on our, let's say, on our own. But there is no follow-up on part of the government, on the part of the government. Remember that Puerto Rico has been going through a tremendous financial crisis. And probably, there is a big mess regarding positions and personnel, having enough personnel to deal with that, and that's probably part of the problem.
Gotcha. And in terms of your mental health folks who are providing some kind of counseling, are most of you guys using in-house staff or using, external staff? And are you using professionals or are you using peer counselors, or, what's the mix?
We have in-house clinicians, in-house psychologists, and also we have a psychiatrist on board.
Okay.
As part of our regular staff.
Okay. Is anybody using any kind of peer counselors or community health workers to assist with smoking cessation efforts?
We had in Columbus, we used the peer counselors,
Okay.
and it was interesting. We worked with the local churches to identify, to work with the housing complex to identify those and work with those counselors.
Okay.
And it was quite successful.
Very good. I would be interested in hearing about that. We were looking at
we use health educators at Macoupin.
health educators. Okay. Yeah.
Sorry, follow-up questions on the health educators. Do they or have they received any smoking cessation training, or these are health educators that are doing all kind of health education?
They've been trained on the
Okay.
American Lung Association, freedom from smoking,
good.
and both groups went on
Very
one.
good.
Yeah.
Excellent.
Now, back to South Carolina. Are you using certified peer specialists? Did I lose?
This is Sarah from Columbus, Georgia,
Oh,
Fort
I'm sorry.
Benning.
I'm sorry. Okay, Fort Benning. Okay, very good. Get my states mixed up. But are you guys using peer specialists, certified?
They were trained through one of the universities.
Okay. Very good. Yeah, because they do have a strong peer specialist program in Georgia. Yeah, that makes perfect sense. Okay, excellent. All right. Well, listen. Just moving on now. The opioid issue. Based on the previous discussion, I think we're in pretty good shape.
Yes, we are.
I don't know if anybody has looked at the write-up, if they have any objections to anything we've got there, or if they want to make any other comments, or have us make any adjustments to kind of bolster up our write-up on opioids.
No.
No.
Oh, you're spot on.
Good. Okay, great. All right. So, and then emergency preparedness. And I want to touch on something real quick on this issue. Somebody said, I think Alan Patterson said, with all the stuff that happened last year, this is a great issue. But as Alan Cintron said, it takes 3 or 4 years to get prepared. So, there's the rub. We have a disaster, everybody's focused on it. We have a quiet year, everybody forgets about it, they don't put resources in it, and then they're not ready the next time around. I think that's one of the major points that we want to kind of get out to everybody. And if we can take advantage of the lessons learned in Houston and in Puerto Rico, I think it would be tremendous.
I would even use as a baseline Katrina in New Orleans.
Yeah.
It took years to make up after Katrina, and many of these things that happened during Katrina could have been prevented. So in Puerto Rico, and for instance, just having backup power in your sites. I mean, that's not something you can do in 6 months or in a year. You need to plan ahead on that.
Yep. Good point.
And the other thing is, how do you switch your mind of not just looking at this from your standpoint of your return on investment, because you probably have that money sitting there, for years.
Yep.
And then out of a sudden you have a hurricane going over you, and then if you're not prepared because you were just thinking on your return on investment, that's it for you.
Yep.
You're dead.
Yep. Great point.
And in regards to emergency preparedness, we would like to focus not only on hurricanes, but I know that other grantees, depending on where the region where you are, probably have another type of natural disasters, like wildfires or tornadoes. So we need to think about all these potential threats.
Yeah, absolutely. That's. I mean, emergency preparedness has to be a 360. I mean, it could be hurricanes, fires, earthquakes, riots, you name it, terrorist attacks.
That's right.
And how do you get ready for that? And I have to mention this as well. It's also a cultural thing you have to build within your staff. Your staff has to be ready.
Okay. Thanks, guys. That's great. And we will add trauma to this. If they won't allow us to amend this, we will at least put it on the agenda for the task force meeting in March. And look forward to seeing as many folks who are able to attend there. So that sounds good. Sorry, right now we're making some adjustments and
it's right there.
Slides.
I mean, one of the public housing trends that we have is the trauma.
Yep.
We included that. It is in the document, but it's not part of the main three topics. But the other one that we also included was the childhood obesity.
Yep.
This being an HHS priority too, and those are the things that we're planning to discuss.
Mm-hmm. And we'll try to make that connection again between the chronic disease and trauma. So that sounds like a great point. I'm just looking at the agenda. We're getting a little low on time, so we're going to kind of rush through a couple of things. If you can, Jose, why don't you talk about primary care radio real quick?
Yeah. We have an idea here at the National Center for Health and Public Housing. We would like to start a new project. This is some kind of pre-recorded sessions talking about all the issues that we just mentioned and probably some other emerging issues. The idea that we have is to record some conversations with you guys and with some subject matter experts from federal agencies, have some kind of panel discussions, and then do either a podcast or a video and post all this information to our website. The idea that we have is that we can also share these podcasts and videos with other agencies, so we can spread the word about the needs in public housing. This is a project that we are planning to start on July 1st. And if you have any ideas, if you have a good program or best practices that you would like to share about the topics that we just mentioned, we can set up a conference call, a video conference, or we can go to the health centers we can go to the health centers and do some kind of interviews. And the idea is to have all these disseminated through our communication channels and probably share the information with the other federal agencies. So that's what we are trying to do. We have noticed that sometimes publications, because of time and other issues, is more difficult for folks to read and go over. And I believe that a video or a podcast is these are easy to go over kind of tools. So that's our idea, and that's what we are planning to do. And if you have any comments or if you have any other ideas, let us know.
Yeah, any feedback on that, guys? Does anybody think it's a good idea or bad idea? Or
to help us find out what's working, it's probably a good idea.
Okay.
What's working
We
where?
I think we're pretty much we made a video on Hurricane Maria. I'll be sending you a copy in case you think you can use some of that.
Okay.
Terrific.
Okay, great. Thank you.
Terrific.
We'll mail it tomorrow morning.
Great. Thank you so much.
Sounds great. So guys, if we do this, I mean, do you think health centers, I mean, would you guys, take the time and listen to them or watch them? We don't want to do it if people won't really get any benefit out of them.
Yeah, we would.
Okay. So,
This is Wayne Rowe. Yes, I would too. I think that's a good idea.
all right. Glad to hear that. All right, that sounds good. Does anybody have any issues or any anything that they'd like to kind of raise up? We're just about to the last minute or two.
No, we still have some time, Bob. We have 9 more minutes.
I'm sorry. We've got competing clocks here. Sorry about that. So we got a minute. So does anybody have anything they want to put on the table?
Well, I think in our case in Ponce, we're pretty much there. I think the topics, I mean, diabetes, the cessation, tobacco cessation, and the emergency preparedness are great issues.
Okay.
I think we're going to have a great conference. And the other areas, I mean, I know NAC for sure will be touching like Washington update and things like that, so that we don't need to go over that.
Right. Yeah, they certainly will. That sounds good. And I will give you guys a quick update, if you like, on the National Resource Center, which is basically a collaborative effort of the National Cooperative Agreements. So, Healthcare for the Homeless Council and the Myra Clinicians Network and, Asian Pacific Islanders group and Capital Link, Fenway for LGBT, and the Oral Health NARO group. We have kind of collectively been working with NAC to try to do 2 primary things initially. The first is to put together a clearinghouse for information, and the second is to develop a single needs assessment. And we're working on those things now. We are, doing some focus groups and so on with involving. In fact, I think we notified folks if they were interested to let us know. There'll be some focus groups with health centers relative to the clearinghouse and relative to the needs assessments. And then hopefully, down the road in a year or certainly 2 years, we will have a single needs assessment as opposed to every National Cooperative Agreement, having their own assessment. So hopefully that will save folks time and get everybody some really good data. So we're encouraged by that. And the clearinghouse, the general outline would be, at its simplest would probably be, and again, this is still in development. In fact, we have a whole session in March on this topic. But the notion would be you'd have one portal or one website that folks would be able to go to and identify different products or services from the different cooperative agreements. And then that would probably, at least as envisioned right now, would probably link up to the information that's offered by the individual cooperative agreements. So again, it should make things a little bit simpler for people as they're looking for information. So again, it's a start. Eventually, I think they're hoping for more collaboration and participation, eventually involving the primary care associations and the health center control networks. But this is a first start at that, and we're still kind of, we'll be having some introductory discussions with the PCAs and HCCNs, probably starting in March, but that's probably going to go on for about a year and a half to kind of make that transition. So exactly what it will end up being, where it's not defined, but it's in process, and I hope it will make things easier for health centers, because as we've talked with everybody in the health centers, and their patients are real customers, and so I hope that will work for you. And periodically, I'll just update you as much as I can. So anybody with any questions about any of that? Okay. Well,
no questions.
No questions? Okay. All right, guys. Well, this sounds good. So we're going to go back and put together, based on the discussion, we are going to amend probably or notify HRSA for or NAC for the task force that will be adding a trauma component to the discussion for sure. And then as far as the training symposium or the conference in Orlando. We will get back to you guys with more detail on the agenda and the logistics. Hopefully in a couple of weeks we'll have a pretty decent straw man for you to take a shot at, and we will continue to refine that. And I want to thank all you guys for participating, and look forward to the next call, which will be I think the way we've got them slated every 3 months. We might ask for a special session before the conference, sometime before that, just to kind of go over some additional details and get additional feedback. So again, thanks very much, and great talking to you all. So take care. And Wayne, I'm waving to you, Wayne. I don't know if you can see me, but
All right.
All right.
All right. Thank you very much.
all right.
Thanks, guys.
Take care, guys. Thanks.
Thank you so much.
All right. Bye-bye.
Take good care.
Bye.
Bye.